Wow. All right. Good evening to our WCCC symposium, and I'm Dr. Sharma. Can you hear us and see us?
Yeah, good morning, sir, and we clearly hear you and see you completely
Yeah.
clearly.
And I'm so
And
happy that a lot of people came. Actually, a lot of your moderators here, they came to me in India Live. The Dr. Sharma, very happy that arranging this meeting, this live case. Although you'll not be doing it, I said, don't worry, I'll be in the outside. So my goal here is just to welcome all, and as you will, Dr. Keeney will introduce the rest of the staff. We will have assembled a full woman team in all the aspects
oh,
in
that's
this room.
lovely.
Yep, including the patient. And I'll just leave it and
Yeah,
wish
that's
you for the great
excellent,
meeting.
excellent,
Yes,
sir.
we'll give great meeting, and I'll
And we
leave it
have,
with Dr. Kini. Yeah,
yeah, we have the in chair Dr. Josna, Dr.
yeah.
Mata, Dr. Zakia Khan, Dr. Shiva Jaz, Dr. Sujata, and a lovely team of discussants Shiva Takkar, Nagbani, Kavita, and Archana. And this is a full house, so you can start your case.
Yes, good morning everybody, and here myself, Dr. Annapurna Kini. I am the director of the cath lab here, and I have my co-attending who is going to be Isha Ranidev. She was a fellow here, trained here by us, and now she's attending who works with me. Then I have two women interventional fellows, Maria Elena and Swati Rao. Then each of my other people will be waving as we talk. Where is Ashley? She's our nurse here. Elena is a nurse here, and we have two technicians, Naira and Marisabel. For imaging, our usual imaging person, they all are in ACC. ACC is happening right now, so most of them are in Chicago right now, and I will have Hideaki, who is a postdoc from Japan, who will be helping us when we need the imaging. So we're going to start with a slideshow. Clicker. If you can show us the first slide. We have nothing to disclose. So this is the live case of, like Dr. Sharma mentioned, it is a woman patient, 66-year-old female with significant risk factors, but most important, presented with angina class 4 actually yesterday to the emergency room here and did not have any troponin. So if you see, 6 months ago, she had a positive stress test with inferior ischemia, but it was managed medically because of multiple prior PCIs. Significant risk factors include hypertension that's controlled, hyperlipidemia that's controlled, diabetes that is uncontrolled. If you can see that her hemoglobin A1C is above 8, and high BMI, which is known, and LDL is okay. CRP again high, which is so it's saying some kind of inflammation is there in this patient. So multiple PCIs over the last 18 years. Twice she has had a non-Q wave MI, but so far because no ST elevation MI or EF has been maintained. And if you see her medication, good medical therapy. So far she has been managed on clopidogrel. Yesterday she had a cath. She had disease of the right coronary artery as well as some moderate disease of the left main and significant disease of the circumflex. So in the past, despite diabetes, heart team discussion had happened. She had declined bypass and PCIs were done. So yesterday she had the right coronary artery PCI done. Today we are going to do the left side. So I'm going to show you the angiogram shortly. So always the way, so here the management will be, we are going to look at the left main and then decide what kind of intervention should be done to the left main, but more important, she had significant disease of the circumflex. So here in Mount Sinai, every case we go through what is called as a OC or appropriateness criteria, which is very important, understanding the patient presentation, risk factors, understanding the syntax score, and then deciding is PCI appropriate, because appropriateness is percutaneous intervention appropriate, or do we have to send the patient for bypass? So this patient, we know diabetic, 1 to 2 vessel disease, possible left main, and we know she has had prior heart team discussion. So in that situation, yes, she becomes appropriate. And the recent guideline also has suggested that that if you have CAD and some kind of, in her case, she of course have presented with the so-called ACS with the no troponin elevation, significant CAD, intervention has to be done, which is very appropriate. And that is where we are today. We can go back to the angiograms. So if you see here, this is, I'm going to show you her, so this is her, EDP was high, that could be, because EF is normal, like we mentioned, that has been well managed, okay, with low EF, normal EF, and now we are with the right coronary artery. If you see her, she did have a PCI of the distal RCA, which looked okay. This is the left system. So, apicaudal, so disease stents in the LAD, mid LAD, which look patent. So if you see the left main in the caudal picture, this because you can see both the bifurcation very well, but if you see that large OM that is coming off, you have significant disease of that OM. This is a cranial picture, stents look good. There is a jailed diagonal which we are not going to see. So the best way to interrogate, now she has lot of stents, I think would be that we can image, understand what the left main looks like. Of course, we will see that the OM disease is significant. So what we'll do is I'm going to use a workhorse wire, from the left main to circumflex, and then do the IVUS. Now we can ask the panel and for any other comments, how they would proceed, anything else they would like to do. Yesterday after the procedure, patient was changed from Plavix to Effient.
Anybody want to ask?
Oh, I fully agree that starting with imaging will be the best choice, because to prepare, maybe it looks in the left main like a bit calcified, so the proper way to prepare the lesion before stenting will be nice. And also assessment, maybe think about physiological assessment of this marginal branch, because it looks severe, but we know that it happens sometimes that even angiographically severe lesion can be physiologically negative. So it seems like a huge procedure. So maybe to avoid stenting, to check it in physiology.
Any other, anybody else has any other opinion?
Hello, Dr. Annapurna. I'm Dr. Josna. I'm happy to see your case from your area to the India, and you helped us even in the WCC 2011 also. You sent a recorded case for us, and this is an excellent case. But even I feel that physiological assessment is going to be the better. But the only thing is, in this physiological assessment, we are going to have a problem of having the proximal left main the disease and the OM the disease. So we can discuss about what is the effects of these physiological effects to really estimate by FFR. But the major problem is, if you are taking other ways of estimation physiologically, probably we can avoid the sequence two lesions which are present subsequently may not have an effect on the distal physiological assessment.
Yeah, point is well taken. Let us just interrogate this IVUS. So show us, go to the distal area, go distally all the way down. This is exactly where the lesion was, right there at that level. Yes. So stop there where the significant disease is. Okay.
Yeah.
So yeah, that is the circumflex what we are seeing. Hold on, go back a little bit behind. Yeah, the distal edge of the stand. No, distal. Go distally. Yes, right there.
Yeah.
Right, a little bit further down.
Further up.
Down, yeah, nothing there. So that's where the so-called maybe normal looking vessel, you see the side branch coming out. Okay, come proximal. Right, yeah, right at the tightest lesion. It's not giving you the where the tight lesion is. Yes.
Yeah.
Go back. Yes.
Yeah, this point.
Yes. Write that. Why you're so this is the Boston Scientific
Abigo.
Agigo, which should be giving
Yeah.
us your you can see the yes, but if you look at it, the AI was giving you your MSA over 11.
No, it was wrong.
Yeah, it was wrong. So we have to be very careful with what you see and how you interpret. So
Yeah.
the orange is the yellow is the lumen, and the blue that you see is the EL. So you have to be very careful with what you see. So that's about 2.2, but then the vessel size is almost 3.0. So these things can hold well only if your vessel size is moderate to large. So it's a 3 millimeter vessel. So we are okay. There is significant disease, but maybe moderate calcium, right?
Yeah.
You say like a one quadrant calcium there. Go back, show us a little bit of that calcium that you see. So this is, yeah, right there. You can see it. So like just more than a quadrant. The other area looks okay. So I guess if something has to be done, we can probably
Cutting
just
balloon.
use a cutting balloon. Yeah, agree. We
Yeah,
don't
it's
need
cutting
anything
balloon.
aggressive. Yeah. Now come back to the left main, all the way to the left main. Looked okay. Let's see how the no, come back inside the stent, because the true left main there is no stent. Yeah, right there. Okay.
That is the carina.
Yeah. No, that's the left main. Go into the ostial circ. Okay.
There.
Yeah. I think we are. So you tell us. You still want me to do physiology here?
No.
Knowing
I
it
don't
is
think
circle, the
this
reason is knowing that one patient has presented with symptoms. Okay, she had RCA ischemia, which took care. Now, inferior ischemia could be even from this large circumflex. Now,
Yes.
it is a very short, small, tight, I would say short lesion, and FFR could be negative. I know what I think they were mentioning is probably IFR. IFR may not be a good idea here because lot of it is a stent in the proximal circumflex. Everybody agrees? Then do we do
Yeah,
just
Dr.
with the balloon?
Kinney,
Yes.
what about the proximal ostial circumflex? Doesn't look so significant. Uh, Proximal and ostial circumflex looks less significant. It's not a very significant lesion. So what do you think? What is your strategy?
So I agree with that. It does not look significant. Let us cut it, put a, I think that also if you see here, the length of the, everything most people will do now, let us say since we did the imaging, that we want the length. But if you see angiographically, you got to stay away from that branching OM. So you would want to put a short stent, maybe a 12 millimeter stent into the OM. Now, when you're doing that, you have to, there's already a stent in the proximal circumflex. So the likelihood of that a small distal circ, which is actually supplying a very little of the myocardium, that you're going to jail that is very high, okay, but not to be scared of that small vessel. Now if somebody is going to ask me a question, if they want to wire this branch, I ideally do not wire the branch because there is so-called angiographically no disease. So the plan will be we just cut and probably put a stent from that ostial, just the ostial OM of about 12 millimeters or so. And then after that, when we are IVUS, let us interrogate again, that's one. Other one is, then do we also see how the ostial LED looks like?
Yeah.
How do we size the cutting balloon? So when we are doing native vessels, so 3 over imaging and 3 over, by there you would go a little smaller, a quarter size smaller. So we took a 275 and we only carry a 6 millimeter balloon with us.
Yeah, and the question from here, our side is also, what about left main? It was also assessed because we didn't see the IVUS from the left main. It is diseased or not?
Okay, you can show the left main again, we didn't say. So now if you see here, I'm having a little resistance, which is normal. The way the, the lesion is tighter, so it would not go. So it's okay, distal edge of the stent. Let's go up here, inflate. So inflation is, you see the significant disease there. Okay, good. We gone up to 12, 14 atmosphere, so we can go to 18. So now we are going to advance a little bit further. We'll interrogate
Okay.
the left main
So,
again. Yeah.
yeah, Dr. Kinney, what is your strategy of taking a cutting balloon about the sizing?
Down.
And you take one size down or
Yeah, that's what. So here the vessel size is 3O, so we have taken a 275. For a native vessel, always go quarter size smaller. So 275 will have about 3 blades. If you are doing a instant restenosis and you want to do the cutting, then you can go quarter size bigger. So if it was now if you take the proximal circ, if you see that it's a 3.5 vessel, you would go with a 3.5 cutting balloon, or if you want, you can even go with a 3.75 cutting balloon, which will have actually ideally 4 blades. So now other thing which we
what
also
atmosphere?
teach. Oh, yeah, this one even native we are able to go. Right now we went up to 16 atmospheres. Yes, and you
16
see that, you see it fully. I'll go on cine. Nice expansion. So do cine and understand if the balloon has fully expanded. If it is expanded, now we have imaging, we know it is only 1/4 calcium. Usually we say mild to moderate calcium respond to, cutting balloon. So it will respond
Are
to
you
cutting
really
balloon.
worried about a eccentric expansion on the one side of the balloon? It's not a symmetrical expansion. So are you really worried about a 16 atmosphere where the balloon is eccentrically expanding?
Not at
That
16,
means
but I think if you're going higher than that, we may be worried. Like if you're going 20, 22, I understand that there is a risk of a perforation with these blades. We have seen that, but that is why we say don't go more than 18. Even for the IFU is 18 to 20 atmosphere. We barely go up to 18 atmosphere. If there is instant restenosis, you can then go higher atmosphere up to 20, 22 atmospheres. Yes.
On IVUS, what is the length of the calcium? It is less than a quarter. But what is the length of the calcium? The size of the balloon you were taken is 6 mm.
You have the length of the calcium there?
Yeah.
I mean, to me, just with my eyes, I saw that probably 6, 8 atmosphere. That's it. Do you have a length? Can you give us the length of the calcium at that lesion?
while he's going into the length of the calcium, this is a very good angiographic result after a cutting balloon, TME3 flow. Do you consider not putting a stent and go metalless with a DCB?
Excellent question. So same thing, you see the vessel size, right? The vessel size is 3O. Can we do that? So far, United States, it has been approved for small vessels. So we probably fall into that criteria. That's number one. The biggest reason we are not using DCB, what is approved to us is the DCB is now approved, but the cost is very high. It's $5,500 per procedure, per balloon. Compared to a stent is $800. Your point is well taken, and like we said, I think before we do that, it's best we image to make sure that we are okay. I mean, if we are doing DCB, but I think we're not planning DCB. What's the length?
8 millimeter.
8?
8 millimeter.
8 millimeters, he's saying. So I went to at 2 different spots, so we have covered that fully. I think if everybody agrees, we can just stent that area and then we will IVUS it again.
3012, sorry.
Right?
Stent. Below 2.
Yeah.
Okay.
We have to see.
3012, right?
Yep.
Science.
Yeah. Yep.
And that's another point. So this is the distal edge, right? The distal edge of the previous proximal circ stent. So very important, what you do is you now make sure you cover from the distal a little bit overlap. That's why we were worried about that the so-called distal circ will definitely be pinched at this time. So we are going with the 3012. Okay. Okay, some dye. I'm going to pull back.
Yeah.
Okay. Okay, some dye now. Yes.
Mhm.
Okay, good. Go up. So 14 atmosphere. Go up again. Nice expansion. Always cine when to make sure the expansion is good. Do we need to post dilate there at one spot?
Yeah.
Go up here. This is the overlap area. Okay, down. Let's IVUS it and then consider post dilation. So we can second time we are going to interrogate the left main. And after that, if this looks good, I will take the same wire, we'll get into the LAD and let us do the left main to LAD.
Yes.
Now, can we do an angiogram? We can, but I think somebody with diabetic, she had a procedure yesterday. Creatinine today is okay.
EDP was
If there
high.
is no need, yeah, EDP is high. Isha is reminding me EDP is high, which is a good point. That if you are doing imaging, just use the imaging rather than do another, angio. Because we are doing patients who have high creatinine, right? A diabetic high creatinine. We are talking high creatinine above 2.5, 2.8, 3.2. These patients, if they need procedure, we are doing IVUS guided. Simple lesions. You can just do IVUS guided where you take a first angio, then you take then you do imaging, and after the entire procedure, you can take a final angio. So limited dye. Okay, so distal edge looks good.
Yes.
Yeah.
Some postal.
Okay, now what I want to do is just, I'm going to take it out, leave it there. Then we interrogate just, shows the distal edge to where we are. That's it. Good, right? Go, stay there.
Yes.
No dissection.
No dissection. No dissection
Why
went.
the MSA is giving us that wrong number?
I think the AI is not working, but
I know.
do you have a
Thank God
do you have a plaque-free area 5 to 6 millimeters? So this
Yes,
is distal to the stent because I can see there's a plaque just
just at
maybe a
the
couple of millimeters distal from the stent edge.
6.3.
Yes. Yes.
Yeah. Okay,
Yes.
that's good. Anything above 5.5 is good. So he wants to see the distal edge. Remember, our stent is on the plaque.
Yes.
Yes, but I think it's okay. No
Yes. No
dissection.
dissection.
This,
Yeah.
No,
you
but
know
we can
that
just take a little more distal,
distal, he wants to go
Yes, you
little
have more than
distal.
50% plaque there.
Yeah.
Yes, you have more than 50% plaque distal to the stent. So
Yeah,
it's
this
not the most ideal, as one would like to call it.
Agree,
Maybe it would
but
have been better to take a longer stent.
I mean at this stage, I know we are doing. Let's us 1 second. Hold on. I do not want to take the IVUS out. Let us go back to the left main interrogation. Then I will take a picture and then we decide. Okay, here. Just the left main. Go IVUS again.
Yeah.
Yes. You have sure.
For imaging the left main, the guide should be disengaged, which is a
Yeah,
very good point. You did that
yeah.
intentionally. So everybody should notice the guide should be
Yes. Yes.
disengaged from the
Go
left main,
slow,
particularly for
millimeter
IVUS.
by millimeter. Yeah.
Yes.
So you
So this is the left main now.
Yeah. Let's start pullback.
Yes. I think looks good. Everybody agrees?
Yeah.
Okay, now let's take a picture and evaluate that OM. Okay. I was trying to avoid long stent, not to jail, because we keep jailing so many branches on this patient. Ready?
that like
So that distal circ is okay. Did not expect anything else. Yes, you see some haziness, but that is something can be left alone. I think
Yeah,
it is
that's fine.
time. It is time also to teach the current generation people to know when to leave it. Okay, it's very easy to decide. Okay, we can keep stenting. We can do that. They have to also know what is reasonable to be left alone. Um, so we already see, look at that branch, despite us being very careful, it is just, that stent is just at that ostium of that branch. If everybody is okay, then we will move on to LAD. What do they
Yeah,
feel?
absolutely. Yeah,
Okay.
that's fine.
Okay, so I'm just going to remove that. So what we normally also teach the fellows is once you're done with the procedure in that side, if you remove the wire, always go low mag and take a final picture just to make sure there is no distal wire perforation. That is an important thing that I have to learn. Now let us see that we will get into the LAD easily. That's into that little branch. To go to the cranial view maybe.
Excuse me, could you
So
tell
this
us
is
the stent size?
so-called VL guide, which is looks like left main is short and mostly facing into the circ. Now, no,
Just delete that.
You want a Leocato?
yeah,
To go a little bit.
I may have to change the curve of the wire also.
Who's the guide of that?
So the guide is facing mostly into the circ. You see that? So now once you advance, it's get a short left main mostly into the circ. So if you have a short left main, the best guide will be an FCL curve. Let's take a picture properly. In the cranial view, did we see it?
Yeah, that's
I
fine.
may have to change the curve of the wire because, okay, this is a good way to see.
It
Okay.
went with the folds to the circumflex, probably.
Yeah,
That's
yeah.
the reason it's lost.
Okay, get me with the previous, get me the wire back.
Right, but in the IVUS it didn't reveal that actually.
Which one? The distal circ, right? I mean, distal left main?
Left many. Even the circumflex ostium. Yeah, circumflex ostium was no, IVUS you should believe. The angiography can be
IVUS is ready, right? Okay.
Sure.
yes, yeah, but IVUS should reveal that actually.
I think we have to see the IVUS once again to see for the ostium of the circumflex. In this view, it is looking like a slightly the diseased
Yeah.
ostium of the circumflex also.
So I changed the curve. You know, it was more of a L-shaped curve to get into the circumflex, L-shaped. But then when you're going to the LAD, you get a C-shaped curve. So you see the left main, the circ is always inferior and posterior. LAD always is a little anterior. In which situation circ? First we try, you know, you pull the guide back, and then try it, which did not happen, and then we go. So now we go back to they want to see the ostial circ again. Hideaki, can you show the ostial circ
Sure.
IVUS?
Sure. Here's ostial circ.
Yeah, it looks okay here.
No, but is there a stent?
Yeah,
Unable
there's a
to
stent.
make out the difference between the stent and the left main, right? Can you just move it frame by frame, because here it seems to be that we can still see part of the stent in the circ.
Yeah, can you come a little bit proximal? Can you show us the carina?
So there is some calcium there that we can
Yeah.
see. So that's possibly giving an impression of a lot of haziness on the angio.
Yeah, this is the carina
Yes,
probably.
that's the carina. So there's some
Yeah.
eccentric calcium, but luckily
But
it's
then-
not very tight.
It doesn't look so tight actually, not critical.
But we don't have the distal left main in your this particular view, because there is a significant plaque on one angle. On the caudal view, we can see there's some significant plaque in the distal left main. Maybe you can see it
So
with
what
the
we'll
LED
do,
pullback.
we'll do it in the LAD.
Yeah.
Probably better off.
Yeah,
Okay, let's go back to another run and let's go to the
Sure.
left main, yes.
Yeah, yeah.
I was ready. I was ready. Yeah, sure.
So now, left, I mean, it has gone
It's just
forward.
sucking in.
Yeah. Circ was okay. So it's against the, not coaxial, you see that? Do you see anything? I can't go, no, in the left main
The
itself.
guide is sucking
No,
The
no,
guide
so if you
is,
see
sucked
here,
into the LED. Yeah.
no, it's not sucked into the LED. So look how the wire bias, you see that?
Yeah.
Yeah, that's what is happening.
Oh, the
Yes.
IVUS is not going in.
Yeah, it's not going because of the wire bias, and it is
Wire bias.
too many stent layers there.
Do you
If you really want
Yeah.
to do here, now we
Wire
have to take another fielder wire and probably go on the fielder wire to
Yeah.
get in.
Or you can take a guide extension catheter.
Okay, get
unless
me a
it's under
fielder
the
wire.
strut.
Yeah, we have it.
Yeah.
Do you think there is some floating strut from the previous stent, and you have gone through one of the strut?
I mean, that's possible. Let us see how the fielder behaves. Unlikely, I'm pulling back. You see that? I'm pulling back. It's in the lumen. See here. It's not behind the stent strut.
Can you do it on a clear stent? Maybe that will give you a better impression of if it's under the strut.
Okay, you have the stent boost.
But without a
You got to be careful doing all these things. I know stent boost is available. Radiation is very high with stent boost. Every time you keep using stent boost. So we need to train our eyes to use regular fluoro and cine. Okay, let's, you have a stent boost ready?
Yep, stand boost.
Put it on.
That's there.
No, that's,
There we go.
Thanks.
it's good?
Yeah.
Let's make sure that you don't see you can see that, right? Can you see? If the problem is, I think you don't see the stent boost.
Yeah, without a balloon, you don't see. You
No,
need-
no, no,
need
no,
a
no.
balloon
That's not the thing. We cannot show it to you guys.
Maybe
Okay.
instead of
Yeah,
IVUS.
so let's not do it. Yeah, we cannot show it to you. I know we done in another live case. I remember they wanted stent boost. We did it, and we could not display it to the audience. They can? How? They cannot. You need a feed. The feed is only from fluoro and hemodynamics IVUS. You can only give 4 feeds, I think. Right? Go back. So we go back to IVUS now.
No, the question from the panel is,
Uh-huh.
without a balloon, can you do the stand boost to see for that?
Without a balloon, yes, you can. My only issue was that she has a pacemaker there. You see that? Could that have interfered? Yes, that could have interfered.
When you get a chance, can we put the IVUS one back up?
So let us see
She
the
doesn't come off
IVUS on the, it'll go on the fielder. Now, there was another suggestion, can guideliner Godzilla can be done? You can, but if you need guideliner Godzilla into the vessel, that's the time you may need a balloon, where you have to dilate the balloon and as you're deflating, advance it, advance the Godzilla. Yeah. We have two. One is Godzilla from the Boston Scientific, and then we have a guideliner. And I think there's one from Medtronic also, which we don't carry. Yeah, telescope. We don't carry it. Yeah.
And in India, we have Guide Plus. It's from a Japanese company, which is very flexible and goes inside. So they use it for CTO and go very distal and really flexible and use lot of Guide Plus.
Oh, okay.
There's a new one now from Biotronic, which has got also some holes for perfusion. So when you use it for the CTO, when you're really deeply engaged with the guideliner, you can have perfusion on the sides so that it maintains the perfusion in the distal vessel, although the guideline doesn't give any pressures back.
And the Medtronic one, which she was mentioning, is
Okay,
actually
I know what's
very
happening.
useful if you've just got OCT imaging. The proximal tip is infrared compatible, so you can use it to image the ostium of the left main also.
So now, you know what? The stent of the circumflex is extending into the left main. Can you see that?
Yes.
Yeah.
Yeah, that's why the IVUS is not going through. So I have gone through those struts.
Yes.
So if I have to do something, yeah. No. So are you able to appreciate that? See, the stent is into the left main, the circumflex
Yes.
stent. So if I have to do something, I'll have to start dilating right now. Okay, maybe time for physiology.
No, in this, we must remember that sometimes, of course, it is not now the case to change the IVUS, but sometimes this volcano, if you do not, you can assess the left main because you do not have something behind. So it's sometimes nice to use especially for the proximal lesions, the volcano IVUS. Of course, the picture maybe are not so nice, but it is sometimes enough and better to advance if we have some dizziness.
Yeah. So let's go back to that ostial circ.
Sure.
Open the FFR. What do you guys suggest? Do we do the physiology?
If you want to assess the distal left main and you
I think,
really
yes.
not able to get the IVUS ahead, so the only option left is physiology. But you did mention that the patient had a stress MPI. So
With
what
the
exactly,
inferior.
which areas were involved? Only
Inferior.
inferior, not
Yeah,
anterior.
no,
So
anterior.
LAD was not really perfected. So it's unlikely that the left main is strongly positive, because if the left main area or the LAD territory was negative, it's a large left LAD.
Yes.
So possibly it's only the circ and that has been tackled. But in case, just to be sure, then you can just do a FFR, which may be a simpler modality to get the wire ahead.
Yeah. Let's do the
You can also
FFR.
do a pullback or to get lesion assessment.
Yeah, but my worry is about the LAD ostium. Unless until go into the LAD, we can't assess the ostium of the LAD and left main, the junction of LAD ostium and the left main. So that area is difficult to assess if you don't have a pullback from LAD to left main.
No, they have a stress MPI, which is showing no ischemia in the LAD territory. It is showing only inferior wall, which is ischemic. And part of it has been addressed by both the RCA and the CX, the OM, which has been managed. So it is unlikely that there is a significant LAD or left main stenosis, which is compromising the flow in the LAD area with having a negative stress MPI. It was a global low flow reserve and a diffuse sort of picture which you had, or a fall in EF, then it could be a balanced ischemia, as you are suggesting. But if they have a clear picture which is showing only, so it's also the non-invasive methods which can give us a lot of information. It's not only we need to do invasive for everybody.
But then if they have that and that doesn't show any ischemia in the LAD territory, then there would be no point doing a physiology now.
We're doing
right?
the physiology from the left main to CX.
Okay, to the CX.
Was the left main prior PCI was mini crush? Right?
Believe so.
But even then, if it is
I
the...
believe so.
I don't think the left main has some stent.
No, it looks that way.
Looks like it's in.
So this
Go
is,
back to
this
the
is
circ
basically
pullback.
Protrusion. Yeah. So there are two different stents in LAD and circumflex, and circumflex stent is protruding into the left main prob.
And the LAD has multiple layers.
Yeah, yeah.
Oh. Okay, so we don't know. So it was a provisional stent left main to circ. With a kissing balloon was done. So we have to make sure we are at the right strut. Okay? Okay, good. Oh, done? Okay, give me the IVUS. I want to try, I tried a different cell. I want to try the IVUS again. If it does not, we have FFR ready, we'll do the FFR. Yeah, what was the point?
Dr. Kinney, the left main looks free of stents in the IVUS. So Is there a
No,
stent in
no,
left
no,
main?
no. I think go back. There is stent in the left main. There is stent in the left main. Even on the angiography right now. So if I go back, see the cine. Are you able to appreciate that? There is stent in the left main, at least 6 millimeter, 4-6 millimeter stent in the left main. And that's what the old report says, that it was a provisional stenting from left main to circumflex. But a final kiss was done. So I have to make sure I'm in the right cell. So let me try this once more, otherwise we have FF already. Okay. It's not going. Okay, get us the.
The left main IVUS. See the left
Ready?
main.
Yeah, maybe the second to go to the.
Yeah, if the LED ostium is gelled, don't you think dilatation of the strut gelling the LED would help your IVUS catheter to float in?
No, we can do that. Then we are committing ourselves for PCI without any disease. Means right now, yes, I can take a 2025 balloon, dilate it and really dilate it, and then finally we have to do a kiss and come out, right? That's one thing. Versus you want to do physiology and then we leave everything alone. That decision we have to make now. Let's do the physiology, right? This is ready. See, once I dilate the stent strut to get the IVUS down, then we are committing ourselves. Is that what we should do?
It's maybe also the solution because it was possible to go through with the IVUS to the circumflex. So to assess very well the distal left main, it could be possible also from the circumflex at the end, if it will be still not the answer, not the clear answer for that.
Assess what? Assess the left main from circumflex IVUS?
But yeah, because we didn't see the IVUS from the left main, or the whole left main.
Can you go back and show it to them?
Yeah.
No stent in the proximal. Hello, yes.
We have done it multiple times. Okay, now let me just take this out, right?
Yeah, see, in this particular one, the moment we come into the left main, then there's the catheter. So we are not able to assess because on the angio, we can see that there is a long left main with a significant amount of disease, or say 50% disease there. But in the IVUS, the moment
Okay, stay there.
catheter
That is the
comes
left
into
main. That's the left main.
yes, and then goes into the catheter. So we can't
Okay.
really see any disease at all in this.
Yeah, but there's no disease to see any disease. This is the left main.
Yes, this is.
But distal left main I can understand. Now go back into the distal left main to ostial circ. Yeah, right there, right there.
So there you have the stent in the
Yes,
ostium,
yes,
right?
yes. Stay there.
Where's the stent?
Now look
Yeah.
look at the. Give us
So that's
MSA
the
there.
LED probably.
MSA. Sure.
Is good. Did you do equalize?
We need to
Equalize.
equalize. We need to
5.657,
flash.
yes.
No, it's wrong. Do it better. Okay. Okay, let us finish the. We can go back. Okay, this is the circ again.
Maybe one stent in the left main. Yeah, maybe one strut. Just one or two struts from the circumflex. That was not stent in the left main. The same. I think it is schematic because it's the one time. Yeah. It's here, yeah.
Are you giving us a, is that the ostial the circumflex?
Osteocircumflex.
So actually, we did see a couple of struts from the circumflex ostium into the left main, but in the rest of the left main, we couldn't see any stent there.
There's no stent in the left main as such. It is it's ostial circ to left main.
Extending from the ostial
Yes,
circ? Yeah. Okay.
into the left main. Yeah, yeah. It's just a few millimeters. I mean, the distal somewhere. Okay, ready? I'm going to start the adenosine. I have two wires actually. I'm going to remove the. We can IVUS again, final. What are you giving us? Can you give us a CSA of the ostial circumflex distal left main? Yes. Show the, now, right now show the FFR. Is that the ostial circumflex you're seeing?
Yes, this is here is osteocircumflex.
Okay, then come to the distal left main.
Yeah, this is
No,
left main.
we are not seeing the IVUS screen. Yeah.
Okay, okay, now you see it.
visible.
Yeah, yeah. Okay, just give us a
Yeah,
cross-sectional
distal
area
left
there.
main was-
Yeah, that's the distal left main. Pull back. Yeah, right there. This is. Okay, give us a CSA there. That's like 8.6.
This PDPA.
This one. Maybe now. Now let's hear.
There. You want to give us a stent area?
Essentially, yeah,
No, more distally.
more distally.
Now is carina and now one frame.
One frame proximal.
Okay, we are seeing the. We are in 1 minute 20 seconds. FFR is 0.86, 0.87.
This with adenosine?
Yes.
Yeah.
I guess we can stop it now. Yeah.
Lowest was
Bring that
0.83.
down.
0.84.
Okay, we are going to do a pullback to make sure no drift. Good, we are at 1. Okay, let us do a final IVUS. That's it. Of the left main to circumflex.
Yeah. Yes.
What is your practice? You use intravenous adenosine or intracoronary adenosine?
Intravenous. So the nurse gives through the.
This might be broken.
Now in this patient, yeah, we do whatever the large IV bore. Usually they have one IV that is attached, and we use that. That's why it takes few seconds before you can see some changes. So let me do a manual pullback of that this particular. Do not do automatic pullback. I'm going to do a manual pullback.
Manual pullback.
And one question also about the adenosine. Do you give a continuous injection or a bolus injection?
No, it's a continuous infusion. Because bolus can give you wrong results. Yes.
Intravenous.
Intravenous infusion.
We have now a rapid scan. It's like the adenosine. It's very
You know
nice.
what? Let me go from here.
Yeah, we can- Yeah. It's also the possibility to use papaverine, but I have never used it.
They're using it at Alst.
Ah.
A lot of we were there with Dr. Collett, so I'm from the Copenhagen.
Okay.
I was there with Dr. Collett. So they use only papaverine.
Okay. So let us see now. Guide is out. Okay. And let us just do the, I'm going to do a manual pullback, okay?
Sure.
So this is the proximal circ. Everybody is able to see?
Yeah.
Okay,
Yes.
good. So now,
We apologize for that, but we are really very interested in that.
Oh, there is a stent with ISR. Yeah.
Yeah. Oh, it's coming there.
Oh, there is a stent with some ISR.
Now the stent and left main, yeah.
Yeah, this part is stent free.
Mm-hmm. But it's also much longer than the previous.
okay, that's it. We're coming up to the aorta now.
So,
Yeah.
yeah.
Mm-hmm.
Show the osteal circ
Osteos.
is okay. I think everything is okay.
Yeah.
Okay, get us MSA right there. There's some intimal hyperplasia, but non-obstructive.
Yeah, it looks less significant with a stable plaque.
Yeah, 10.5. Okay, okay, keep
Yep.
coming back. Proximal, yes, proximal, slow.
Now we are coming to the left main, yeah.
Yes, now there you give us MSA there.
Yeah.
And here I think it's what we see like a most
Yeah.
significant.
Okay, can you do a manual MSA? Don't go with that.
Yeah.
This one.
MSA.
Yeah, there is a little bit maybe before. Down. It's less than 6.
Yeah.
No, it's 5.93, please. If he moves it a little bit, it will be 6.2.
Yeah.
Would you like
I
to
don't think.
consider an FFR for the?
You can go also
So-
distally a little bit more down. So it's,
Yeah, you have to.
Would you like to consider FFR for this circ? No.
No,
The virus-
they've already done a FFR, which is negative in the left main. With a 5.9, 5.6, I think it's an intermediate lesion with a FFR negative, so medical follow-up.
We
I
did an
think this should be
FFR
left
across
alone.
LAD, right? LAD to left main. It was not across the circ. So, I mean, the wire is open. Would you, I mean, we can rather do it only, just to be pretty sure.
We'll tell you the
we should
number
leave it to the
right now.
operator's
We'll leave it.
discretion.
For the
Yeah, yeah.
circumflex.
I think we are coming to the
That
end
comes
of the
as a
session. It was a beautiful case where we demonstrated how we can probably do physiology, IVUS, and then make a decision, especially in this lady with
Yeah.
the multiple stents, because even if you want to go behind, okay, this particular ostial circumference, which is again borderline, right? Borderline. How are we going to handle it? Then we will have to do a 2-stent strategy again. It becomes a very complex intervention if you are going to do this, because you've got to go through the stent start of the circumflex, open it, then you have to, make sure you are fully doing proper preparation of that ostial circumflex, and then probably do a 2-stent technique. Doing that kind of a complex procedure for a moderate lesion is something we could leave it alone. Her significant disease was that OM, which we took care. She had significant disease of the RCA, which we took care. And it's time to manage her medically.
Yeah, it's an excellent demonstration of a physiology, imaging, and decision to leave it on medical follow-up. Excellent case. Any comments from the panelist or chairpersons?
no, it was really excellent case. We have learned that we should use sometimes complementary physiology and imaging. So it's very great. A lot of educational things. So thank you very much for that.
Dr. Kini, the only thing in India now we are doing much more DCB. So we use drug-coated balloon even for the circumflex, which is having some new arthroscosis, is a borderline. If I'm in doubt, I'll do a cutting balloon and do a DCB to the left main to circumflex, and leave it with a good lumen.
Yeah, that's excellent point, and I think that is something everybody should do it. I agree with that, but here because of the cost constraint that we are not using DCB that often, and we are still part of a few trials. We are part of a native small vessel disease. We are part of a ISR for small vessel disease. So until we have the results of that, we cannot be 100% sure would it be a good treatment strategy. But I think your point is well taken. When it is complex like this, it's good to do cutting balloon and do a DCB to the that area. And also very important where it probably works is side branch. You don't need to do two stent strategies anymore. Maybe you can just do provisional everywhere and take care of the side branch with the drug coated balloon.
And I fully agree that we do not have evidence data for the large vessel for
Yes.
DCB. Courage-free study was more than in the population where the diameter was over 3.0 or even 2.5. It was not it was inferior for the comparison to the test. So we are still in the waiting time for that.
So we conclude the session here. It's a lovely demonstration, and thank you very much for live demonstrating this case to this Women Cardiology Conference. And thank you very much. A great round of applause for the nice demonstration of life. So thank you very much again.
Okay, thank you. Bye-bye.